Welcome, Professor Laura. We
Thank
are
you.
Happy to have you with us this afternoon. And Professor Laura Rienzi is Professor of Biotechnology in Assisted Reproduction. She is a Senior Clinical Embryologist Laboratory, and she is a Director of the Genera Centers for Reproductive Medicine in Italy. She is concerned by all areas of IVF laboratory and published about 200 articles and reviews. You can correct me, Professor Rienzi, if I made a mistake.
It's fine,
So,
thank you.
Thank you. So Professor Rienzi will treat for us the very interesting subject of oocyte cryopreservation. So do all clinics achieve success? So go ahead.
Thank you for the nice introduction. I'm very happy to be in Morocco, although virtually. Bonsoir tout le monde, ça me fait très plaisir d'être avec vous. I'm going to speak English because this is the rule of the Congress, but you know what, I speak French if you have any question. So this is my conflict of interest disclaimer, nothing specifically related to this presentation. And I'm going to try to make an overview of oocyte vitrification. It has been like about 10 years that this technique has been applied, I would say, worldwide. And this is because the technique has changed and vitrification has been introduced. And it has been like a revolution or a game changer in our field, because as you can see, as you will see, vitrification has offered a lot of new opportunities, not only for the lab, for the clinician, but also for all patients that can now access to the treatment. So why I'm saying that vitrification is really a game changer, not only for oocyte, enable fertility preservation, enable egg banking for oocyte donation, but also to enhance the IVF possibility to get a pregnancy. If we can cryopreserve successfully oocyte and embryos during an IVF cycles, of course, the patient will have more chance to have a baby cumulatively, but also have a chance to access to single embryo transfer. We are not losing the second one and the third one, and we can make a safer treatment for our patients. And also we can do a lot of new applications like PGT, and this is possible because we can cryopreserve successfully biopsied embryos. So a lot of opportunities, all the new technology are possible today in IVF because cryopreservation is performed in a very efficient way through vitrification. So vitrification is really a game changer, no doubt about this. Do we have clear evidence that vitrification is better than slow freezing? We have tried to make this exercise for the WHO some years ago. We have performed a systematic review and meta-analysis of the literature, and we found very few randomized controlled trials. So we were only able to say with a moderate quality of evidence that the cryosurvival was better, and in turn, the clinical pregnancy. But you know why there are no so much randomized controlled trials? Just because the technique is so efficient, is self-evident, but nobody is doing randomized controlled trials. So it's not for sure that randomized controlled trials are really needed when specifically a lab technology is so efficient. For oocyte, it has been more difficult because the oocyte is much more sensitive. It's a bigger cell with a different membrane permeability, with a meiotic spindle. It's, of course, very sensitive to aging. So the oocyte has been difficult. It has been difficult with slow freezing and has been difficult with vitrification. Imagine that we have only one randomized controlled trial comparing the clinical efficiency between slow freezing and vitrification, and this is in favor of vitrification. But we have some studies, some randomized from RCT with sibling oocyte, which is a very nice model when you look for outcomes that are related to the lab. So same cohort of oocytes splitted between slow freezing and vitrification, and all the studies demonstrated an advantage of vitrification as compared to slow freezing. But of course, to have a survived cell is not enough. We want to have a healthy embryo. So now we have some studies looking to sibling donated oocyte. What is the laboratory outcome? Let's say the blastulation rate, but also the aneuploidy rate. So we can say that vitrification is not improving the quality of the egg. Of course, any extra manipulation is somehow affecting our cells. So the blastulation rate is slightly lower with vitrified oocyte, but the aneuploidy rate is really not different. So this is one step certifying the safety of the technology. So again, slightly less blastocysts when you use vitrified oocyte compared to fresh oocyte, but no difference in implantation, clinical pregnancy, and euploidy rate. So this is very important. So although we didn't have so many randomized control trial, ISRM and ASCO has recommended vitrification for slow freezing early in 2011 already. And it's very important that ASCO has looked to our technology to advise oncologists to propose oocyte vitrification prior to a chemotherapy or gonadotoxic therapy. So you see how it is important to improve our technology because we can offer this treatment to a larger patient population, in this case, young women that has to do an oncological treatment. Now we have to be efficient because vitrification is efficient in RCTs or in specific labs. Are we able all to perform the same as Anna Cobo in EV that have shown that fresh and banked oocyte in egg donation have the same results? Yes, there's a lot of different centers that has confirmed this observation. We can really use cryopreserved oocyte for egg donation without affecting the clinical results. And it's what we are doing in Italy today. We don't have donors because the law has changed recently, but we can import oocyte from other countries and provide egg donation today. Also, the practice committee of ISRM has said that there is no differences when you use a slow freeze, fresh donated oocyte or vitrified oocyte, and it's recommended for donation. What about fertility preservation? Everybody's asking, how many eggs do we need to have a pregnancy when you do fertility preservation? We don't know. We don't know how many eggs are needed to obtain a pregnancy in fresh cycle, and it's a little bit the same. It depends on the quality of the oocyte. And probably the quality of the oocyte depends mostly from the age of the women. So Anna has made these Kaplan-Meier figures which to calculate which was the live birth expectation according to the numbers of oocyte that has metaphase 2 oocyte that has been vitrified. And you see that with about 15 oocyte, you have about 70% live birth rate. And with 24, you can even reach more than 90% live birth rate. And this is true for infertile population or with oncological population. Endometriosis is also an indication for fertility preservation, and it's efficient also in this case. Another question that many clinics is asking is how long this oocyte can be stored. There is conflicting results in the literature. But I would say that we are quite confident that few years doesn't change anything. And here you have a very nice study from Ludovico Parmigiani showing that 1 to 3 months, 4 to 6 months, 7 to 48 months doesn't change the outcome in terms of any KPI that you are looking for. Pay attention. Sometimes you will find some studies saying that embryos that has been cryopreserved for longer may have lower results, but this also depends on the quality of the embryos. Because of course, if it is a second or third choice embryo, so it's not the duration of cryopreservation that will affect the results, but the fact that it was the second or the third choice. So when we do this kind of analysis, we always have to correct per quality of the embryo that are cryopreserved. Now, what is the expected survival rate that we should have when we deal with oocyte vitrification? It has been defined by international societies like ALPHA, showing that according to the type of a protocol that you use or according to the type of oocyte, donor, or infertile population, your expectation in survival rate should be between 85 and 95%. How do you control that? It's not easy, because if you have small numbers, you can have high variation in survival rate. So you have to use a control chart. A control chart is a monthly or weekly, in our case, because we are a big group, chart where you report the survival rates that you have in your lab. And of course, you can see that there are variation, but this variation should be in between 2 standard deviations between your KPI value. If it goes down, maybe you have a problem, and you can intercept the problem and find a solution. But sometimes you are higher than 2 standard deviation, or even higher than 3 standard deviation. You have also to redefine protocols when things are going well, not only when things are going bad. So my suggestion is really to track your survival rate and try to see when something is wrong, but also when something is good, because this can bring a lot of improvement. So is it consistent in the literature? Do we have same results in Italy, Spain, or in US? I will show you from the register that oocyte donation with cryopreserved oocyte has about 35 to 40% live birth rate. And this is the Italian registry. But if you look to the UK registry, you are again between 30 and 35%. If you look to the US data, some time ago, you see 2013, 2015, it was shown that fresh oocyte donor were performing better than cryopreserved donor oocyte. And that was really, there was a lot of discussion in the literature between these results. Was it because it was a training period? It was the beginning of a technology? How do you explain? Probably because no cumulative data were provided, but also because people were not trained to perform oocyte vitrification. Because if you look to the results in the US registry 2019, there is no difference between singleton birth with fresh or frozen vitrified donor eggs. So I would say that today, with the experience, we can say that frozen donor eggs by vitrification is a validated and standard and reproducible technology. So we have different clinics. So this is very easy, because we can really test new technology, and we can also test new protocols or procedure. So when the law has changed in Italy, and we were able to do oocyte vitrification in our country, but without any donor, we decided to import oocyte. But we didn't know if the right number of oocyte, vitrified oocyte to import was 6, 7, 8, or 9. So we did a beautiful study that is published on Reproduction 2020. This is the way to start a new protocol, to do it really with a scientific approach, and publish it, because this helps, the community, the Italian community, to choose the right number of oocyte, the right day for transfer, and to see, and also for the patient to explain which is the real expectation that they should have with this technology. We were able also to compare the different clinics, so the survival rate, the fertilization rate, the blastulation rate between the different operators. The red bar is our KPI. As you can see, we can check if everything is going well in the different centers, and here's the chart that we have weekly. In this way, we were able to standardize our protocol with a bank belonging to the network. So we had a perfect control of the whole procedure, from the donor selection to the donor eggs cryopreservation, through the shipment, and then the utilization in Italy in different centers. It's an incredible opportunity. We were able to offer to thousands of patients this technology in a complete control way, from Spain to different centers in Italy, as you can see in this map. What were the results? Very consistent between different centers in different areas of Italy. And as you can see, all performing better than the KPI that were set. So of course, we are readjusting now the KPIs. And here you can see the chart for the different clinics every month. So standardization, new protocol, scientific approach, this is super important when you deal with a new technology. And probably automation will even help to accelerate with this process. Because as you all know, vitrification is a manual procedure. And when it's a manual procedure, you may have a lot of differences in timing, in volume. You see the operator has to take the drop, has to move the oocytes from one drop to the other. The timing is not really precise. The volume around the cell cannot be completely standardized, especially when you put the oocyte up on your carrier. So I'm just going to show you this. This is when you put your oocyte on a carrier. Now, this was the warming, sorry, but this is also a sensitive moment. So here in the Joby paper, you can find every single detail about the procedure we use in our lab. So this is really the moment where every single operator is doing in a different way, and there is a different volume around the cell. So what about the standardized technology? Of course, we have to use machine, and machine are now available on the market. They are not fully automated, but I think we have to keep an eye on this. And my philosophy is that more patients will access to the standardized and optimized technology better the IVF treatment will be globally. So we have really, as embryologists, to think about something that will help us to perform the same everywhere. And also, when you use an automated machine, you may have the opportunity also to standardize, but eventually even create development and improve a protocol, because you can get more information and you can analyze this information to set new protocols. So to conclude, vitrification is really a game changer, has changed not only the survival rate, but also the structure of our labs, because it's faster, it can be implemented at any moment, it can be standardized, it gives more accessibility to patients, and also more room for the gynecologist to decide if to transfer, not to transfer, transfer less embryo, and rely more on cryopreserved cycle, which is really essential to date. I foresee that the majority of embryo transfer will be performed with cryopreserved cells. So I thank you very much for your attention. I thank the Moroccan Society to have invited me, and I thank all my colleagues all around Europe to help me every day in my work. Thank you very much.
Thank you. Thank you very much, Professor Rienzi, for this interesting presentation. And we wish see you in Fez in November. And,
exactly. I will be in Fez in November.
Thank you. And we're going to continue with the